How do we treat patients with lupus nephritis? Depends on a lot of conditions. Number one, the biopsy report is very important to find out what the class of lupus nephritis is. Number two, what is the activity and chronicity scores on the biopsy? And number three, what else is going on in the body from lupus, and what are the preferences of the patient? What does patient want to do? As you heard, the treatment is very, very aggressive treatment which has a lot of side effects. So if you are diagnosed with class 1 and class 2, you usually don't need any immunosuppressive treatment for treatment of kidney disease from lupus. Usually treatment whatsoever you will give to a patient who is having lupus elsewhere in the body, that you will continue in a patient with class 1 or class 2. And the goal of the treatment treating in patients with lupus nephritis is to make their kidneys go back to normal, which means they should not lose protein, they should not lose blood, and if they had high number for BUN and creatinine, that should go back to normal. So that's the goal when we are treating patients with kidney disease. So in class 1 and class 2, usually nothing special is given. It's usually steroids if you need for anything else in the body from lupus, along with Plaquenil as well as some ACE inhibition therapy. So this particular medication called ACE inhibition, which includes captopril, monopril, fosinopril, or Cozar as one of the angiotensin receptor blockers, are the one which have been shown to delay the progression of kidney disease in patients with lupus nephritis. And a spironolactone, which antagonizes a hormone produced in the body called aldosterone, has also been shown to minimize the damage and reduce proteinuria, at least in animal studies. This has not been tried in humans yet. Again, patients treated with ACE inhibitor therapy with class 1 and class 2 lupus do much better long term as compared to patients who do not receive ACE inhibition for treatment of lupus nephritis. So then comes the question, who needs treatment with immunosuppressive medication? And class 4, as you heard, is the most aggressive form of lupus nephritis, along with some patients with class 3 lupus are the one who need treatment with immunosuppressive treatment. And treatment is divided into two phases. One is induction, which is the phase 1 when lupus is very active, very aggressive. So you need to give strong medication to really control the lupus so that the damage in the kidney can be given chance to recover. So that's called induction, and induction usually is for 6 months but can be shorter or longer depending on how patient is doing with the prescribed treatment. And this is followed by maintenance, where we give treatment because lupus, as it quiets down with treatment, as you reduce the doses of the medication, has the tendency in the kidney to come back, what is called as relapses. The more relapses some patients have, the higher chances that they are going to lose kidney function with time and progress to end-stage renal disease. So treatment is continued on for many years actually in some patients depending on their response. So maintenance therapy, usually with immunosuppressive therapy, is continued for at least 24 months, but can be longer in some patients depending on their response. And the goal of the treatment is to induce remission of the disease. When I say remission, it means that the protein in the urine has to go below 500 milligram per day. They have to, the urine analysis should not show any red blood cells or cast under the microscope, and the kidney function should either get better or should at least stabilize. So induction is given with the goal to achieve all three of those components. And usually we use immunosuppressive medication, usually systemic steroids, either orally or intravenously, followed by oral therapy, along with some kind of immunosuppressive treatment. And usually the drugs which we use to treat immunosuppressive treatment are either cyclophosphamide or some other medication. So cyclophosphamide could be given orally. This used to be the traditional way of treating patients with class 4 and some class 3 lupus nephritis patients, to give orally or intravenously, and it could be given in a dose ranging from 500 to 1000 milligram per meter square, and usually given in monthly doses if given intravenously, that you give one dose each month for 6 months and then quarterly for next 2 years. And this was based on this landmark study from NIH, where patients who received combined therapy, Cytoxan monthly for 6 months, then quarterly for 2 years, along with corticosteroid, induced remission in much higher number of patients as compared to patients who just received either Cytoxan or prednisolone alone. And this not only was able to achieve remission in much higher number of patients, but the remission was maintained for a long time, 10 years in this follow-up, after they went into remission. And because of the long-term remission, very few patients needed to go on renal replacement therapy. So this became the traditional way of treating patients with class 4 lupus or proliferative lupus with Cytoxan and steroids. And then came this Euro-Lupus trial which showed that using a low dose of Cytoxan instead of 500 to 1000 milligram per meter square, giving them only 6 cycles of 500 milligram and then switching them over to Imuran probably is as good as treating patients with full dose Cytoxan. So in this, remission rate between the low dose and the high dose patients given Cytoxan along with steroids was pretty much similar. And then problem with Cytoxan being that Cytoxan is a very strong medication. It lowers the immune system of the body. It makes patients susceptible to infections. Few of them can be life-threatening. And as you know, lupus is a disease of female of reproductive age group, and it destroys their egg cells in the ovaries, lowers their fertility potential, and as you heard before, it is toxic to the bladder, urinary bladder mucosa, and causes what is called as hemorrhagic cystitis with the potential to develop bladder cancer later on. So a search was made for use of a medication which probably will not have these bad side effect profile. And then came the trials using Cellcept or mycophenolate as a treatment for proliferative lupus nephritis. In this study, oral Cytoxan by mouth was tried in Chinese patients with diagnosis of class 4 lupus nephritis and was shown to be as good as oral Cytoxan to induce remission. And follow-up in this study, the first one published 12 years ago, was for 1 year. And then came follow-up on these patients 5 years later, showing that even 5 years later, the treatment with mycophenolate was as good as treatment with oral Cytoxan. But problem was, this was a Chinese study. It wasn't tried in high-risk patients like African Americans and Hispanics and Asians. So there came this trial from Miami where they used Cytoxan, IV Cytoxan, and compared it with oral mycophenolate, where they recruited 50% of their patients with African American and Hispanic background. And they showed that the remission rates in these patients were pretty much equivalent between Cytoxan IV as well as mycophenolate. And then we had this international trial using IV Cytoxan, again oral mycophenolate, again showing the same results, that mycophenolate is as good as Cytoxan. And since then the guidelines have changed. So in a patient who is not otherwise very sick, does not carry a very bad disease on the renal biopsy, the treatment protocol is to give them oral mycophenolate along with steroids, and give them at least 3 months of treatment to see if they respond and able to go into remission. And if they are not, then you can switch them over to Cytoxan in an attempt to put their kidney disease into remission. So there are multiple options for induction. You can use typical NIH protocol, as I mentioned before. You can use low dose Cytoxan, or you can use mycophenolate. We usually go with this therapy first and then switch over to Cytoxan if patient does not respond to mycophenolate or prednisone. And prednisone usually is given intravenously for first 3 days and then switched over to oral medication. In some patients, even if you give them Cytoxan according to NIH protocol, they sometimes do not respond to treatment. In those patients, we have some other options which are available to induce remission, and one of them being plasmapheresis. In some patients it does work, even though randomized trial did not show to be of any benefit. In some patients, calcineurin inhibitors like tacrolimus or cyclosporin can be used. Rituximab is another medication, even though not approved by FDA for lupus nephritis, but has been tried in this particular trial, lupus nephritis trial assessment with rituximab, and has shown that as compared to mycophenolate and prednisone alone in resistant cases, it can induce remission, either partial or complete. As I mentioned before, remission means you want to decrease the amount of immunosuppression, and as you decrease the amount of immunosuppression, the disease in 50% of patients can come back, which requires the ongoing use of immunosuppressive medication. So usually we continue treatment as maintenance therapy with these medications. The treatment usually we use are either Cellcept or azathioprine along with very small doses of prednisolone, and this is continued till you make sure that your patient continues to show the signs of being into remission, which means their kidney function remains stable, the protein in the urine continues to be less than 500, and their urine examination remains very inactive. In membranous lupus, not everybody needs treatment unless it's accompanied by stage class 4 on the biopsy, or some patients, if they are losing a lot of protein and develop nephrotic syndrome where the whole body is swollen, only then you go ahead and treat those patients with immunosuppressive treatment. And usually the drug used to treat class 5 lupus, which is lupus membranous, is mycophenolate. But if for some reason patient is not able to tolerate or cannot afford a mycophenolate, then you have the choice of using either IV cyclophosphamide or cyclosporin. And in multiple studies, mycophenolate has been shown to be as good as IV cyclophosphamide with better side effect profile, so patients and physicians prefer to use it more for treatment of lupus nephritis. As Dr. Schwartzman mentioned, certain risk factors will tell you if somebody is going to do well after diagnosis of lupus nephritis on treatment or not. Some factors which we take into account for making out if patient is going to respond to treatment or not is how the biopsy looks. The more aggressive the biopsy is, the more necrosis, the more red stuff you see on the biopsy, the more crescents are there, the more cells are there. It just tells you that the disease is very, very aggressive and needs very aggressive treatment. And if there is a lot of scarring seen on the biopsy, then that means the aggressive treatment is probably not going to work, and you need to back off on the immunosuppressive treatment because it's risky for the patient. And some other factors which will tell you if somebody is going to do well or not is if they are hypertensive or not, if their kidney function is elevated at the time of diagnosis of kidney disease from lupus, if they have any very delay in therapy, if you are thinking too long about treating the patient or patient is taking too long deciding between cyclophosphamide versus mycophenolate or Celsep, then it can just make things worse because there is ongoing inflammation in the kidney, which ultimately can give rise to scarring. And as Dr. Schwartzman mentioned before, patients of African American ethnicity don't do well with diagnosis of lupus nephritis, and patients' poverty has been shown to be a risk factor for associated with poor prognosis in patients with lupus nephritis. So, in various studies, no matter what you do, even if you give the best treatment available to the patient, still some patients do not respond to the treatment and develop end-stage kidney disease. So somewhere from 15 to 30% will progress to end-stage renal disease. With the new treatment, if you are able to obtain remission of the disease, the 10-year survival rate for the patient and for kidney is excellent. But if you are not able to maintain that remission or attain remission and more relapses take place, then the 10-year survival rate for kidneys is only 30%. So a lot of patients can develop end-stage kidney disease because of lupus nephritis. And as I mentioned, this survival rate is lower in African Americans, and patients develop end-stage renal disease where they become symptomatic because of the retention of the poisons kidney usually dump out in the urine, and for them you have to start some kind of renal replacement therapy, and there are choices between hemodialysis, peritoneal dialysis, and some of them opt going for kidney transplant straight away without even being dialyzed. So hemodialysis is a procedure where you use a shunt to take out blood from the body because you need to clean out all those poisons from the blood, and you run it through a filter in a machine, hemodialysis machine, and this is done every other day, 3 times a day for almost 3 to 4 hours depending on various variables of the patient undergoing dialysis. And patients do very fine on dialysis if they ever lose their kidneys from lupus nephritis. Their 5-year survival rate is just like any other patient on dialysis, more than 90%, and they can do either hemo or PD, but most of the patients opt for hemo. 82% of patients go for hemodialysis in a study shown from Brigham last year, and usually there is an increased risk of every dialysis patient to develop sepsis and increased risk of death in first 90 days of dialysis, but after that the risk usually goes down, and that has to do with some catheter infections and other things. Peritoneal dialysis, where we use the peritoneum, the abdominal membrane for dialysis, can be used in patients who have lupus nephritis, but is not very much liked. Only 12% of patients opt for peritoneal dialysis from the same study done at Brigham. And patients, there is some evidence that patients who do peritoneal dialysis and then go on for kidney transplantation do somewhat better than patients who undergo hemodialysis. So maybe something to keep in mind for those who suffer from end-stage renal disease. There may be high risk of peritonitis, which is the infection in the in the fluid which we use for dialysis in the abdominal cavity. And as you learned before, kidney transplantation is a very viable option for a patient who will lose kidney from lupus nephritis. Not many patients opt for preemptive transplantation, which means without being dialyzed, they go straight to kidney transplantation. And usually a donor kidney works fine in a patient who has systemic lupus erythematosus. You just have to make sure that their lupus is very inactive and they are very compliant with the treatment before you transplant somebody else's kidney in their body. And lupus usually doesn't come back in the transplanted kidney. The survival rate, as you learned before, is very good, as comparable to anybody else who undergoes transplantation because of no other reasons for kidney disease. And some patients who develop very aggressive disease from lupus nephritis, it is recommended that they do dialysis for first few months and then undergo transplantation. And as you learned before, antiphospholipid antibody syndrome can give rise to various clots in the body, and if you are undergoing transplantation, there is a risk that you can actually form a clot in the new kidney and lose the kidney. So a patient with a positive antiphospholipid antibody usually is not recommended to undergo kidney transplantation unless full dose anticoagulation is started in those patients. Even with that, it remains a high risk situation. And with that, I will thank you for your attention.